Hello and welcome to the November edition of the Digital Health Virtual Series. My name is Matt Rayner. I am the publisher here at Healthcare Innovation, and today is all about population health management trends and best practices. We have three fantastic sessions lined up for you today, and whether you are watching this content live with us here today on November the 18th, or you're consuming this content on demand, we want to thank you for being a part of this program. This virtual event would not be possible without the support from our partners. And so we would like to give a big thank you to our friends at LexisNexis Risk Solutions, SDLC Partners, and NeuroFlow for making today's event possible. If you have questions for our faculty today during any of the sessions, these sessions are designed to be interactive, so do not be shy in submitting any and all questions that you might have by utilizing the chat functionality within the Zoom platform. Okay, I would now love to officially kick off our opening session on social determinants of health and health data exchange. And so I'd like to welcome on our editor-in-chief here at Healthcare Innovation, Mark Haglin, who will be moderating this opening session. Mark, are you with us?
I am with us.
Take it away.
Thank you, Matt. I am with me. Welcome, everyone. We're so happy to have you here virtually. We really appreciate your participation. We have a wonderful constellation of industry experts here, and I'm going to very briefly introduce them, and then we'll talk about the social determinants of health, health data exchange, and other issues around SDOH. I'm just going to introduce them in order of how they appear in our program, but of course, all are equally amazing professionals and leaders in the field. Unfortunately, Ashley Brown was not able to join us, but her colleague, Kirsty Cleverkamp from the Colorado Health Institute is here. Deb Donovan from Highmark Health is with us. Emily Mortimer from LexisNexis Risk Solutions. Janine Sivi from SDLC Partners, and Klaus Madsen from Cities Changing Diabetes. So welcome to all of you panelists. So great to have you with us. I think what I'm just going to do is go in the same order. We're going to start at the very beginning, simply having each of you spend 1 minute, a minute-ish, your title, your role, and a tiny bit about your organization, because we are very heterogeneous today. We have leaders representing many different types of organizations, which is of course what we need to discuss SDOH. So why don't we start with Kirsty, if you'd like to begin. Just tell us very briefly about yourself and Colorado Health Institute.
Thanks, Mark. Hello to you all. Thank you for having us be a part of the panel. My name is Kirsty Cleverkamp. I'm one of our program managers on the team at Colorado Health Institute. And my role is really involved in working with our cross-sector partners, including health, human service, and community-based organizations, as we think about how we can collaboratively work together across systems to better address social determinants of health. And this really fits into the larger picture and commitment Colorado Health Institute has to bring research, analysis, and insights to our leaders across the state to improve health for all. And so I'm really happy to be here today and share a little bit more about our work related to social determinants.
Thank you so much, Kirsty. Welcome. Great to have you. Deb Donovan, would you like to introduce yourself and Highmark Health?
Sure. Thank you, Mark, and thank you for having me. I work for Highmark Health, which is one of the largest Blue Cross Blue Shield plans in the country, and we also have a large delivery side. We have a 13 hospital health system as part of that. And my role at Highmark is I'm the Vice President of Social Determinants Strategy and Operations, working across our enterprise. As you can imagine, in these large companies, there's a lot of work that's occurring, and our job is really working horizontally and coordinating across the large companies, and then advancing strategically so that we are, again, addressing the social risk for those we serve.
Wonderful. Thank you so much, Deb. We really appreciate it. Emily Mortimer.
Yes, hi, and good morning, good afternoon, depending on where you are. I'm Emily Mortimer. I work for LexisNexis Risk Solutions in our healthcare division, and my role is focused on healthcare strategy for social determinants of health. LexisNexis, as some of you might be familiar with, is a data and solutions provider, and the work we do in healthcare is similar, providing solutions for business problems for healthcare organizations. Specifically within social determinants of health, we provide information that allows healthcare organizations to more broadly understand the risk profile of their patients or their member populations, both kind of down to the individual detail level, as well as to kind of shortcut some of the stratification of those risks with models and predictive risk scores. So we're really happy to work with a lot of different organizations within healthcare and further the goals of social determinants.
Wonderful. Thank you so much, Emily. Great to have you. Janine, welcome.
Thank you so much for having me. So my name is Janine Sivi. I'm the Director of Healthcare Solutions at SDLC Partners. We are now a proud member of the Citius Tech family. Citius Tech is a 100% healthcare tech company serving payer, provider, med tech, and life science. My team's mission at SDLC Partners is healthier lives via frictionless healthcare. So we focus on that within organizations, administrative and also pop health management, care management. And that means getting data, systems, processes, and businesses aligned and all talking to each other. We're increasingly doing it across organizations. So especially as we flesh out care management, connected care, social determinants, that requires doing all of those same things, which are already very challenging inside a single organization across many. And that's what we wake up every day thinking about.
Wonderful. Thank you so much, Janine. And Klaus, last but not least, welcome.
Thank you so much, Mark. It's great to be here with all of you. I'm a public health and public policy consultant with my own firm, Klaus Health Solutions, and Novo Nordisk is my primary client. I work with Novo Nordisk in the US around the Cities Changing Diabetes initiative. It's a global initiative with 40 cities who are coming up with their own solutions to prevent obesity and diabetes, and I'm the lead stakeholder engagement consultant in Houston and Philadelphia. I also consult with Novo Nordisk at the global level, and I've helped them with most recently an innovation challenge called the Healthy Food Challenge.
Wonderful. Thank you so much, Klaus. I just love the diversity of our panel today. Everyone is working on different aspects of huge societal issues. So I appreciate it very much. Welcome, everyone. And let me just do a very brief level set on the landscape. We all know that the pandemic has been, first of all, of course, terrible for the entire world, but also revealing, right? Because one of the things that's happened in the last 18, 20 months is the full realization of the extent to which there are discrepancies and inequity in the healthcare system and in how people are living their lives in the United States. So one of the things that was happening, of course, before the pandemic hit, but which really got a fire lit under it, was this search for somehow connecting communities, individuals and communities better to care and to care in the broadest sense, the societal sense. And one of the key elements in that, as we all know in healthcare, and everyone on this panel is involved in this, is pursuing the integration of social determinants of health data and information into broader information, so that individuals who are patients, plan members, consumers, residents, and citizens can all receive adequate care and their health can be improved. So one of the things that I think is fascinating right now is that on the one hand, SDOH work had been pursued, obviously, prior to the pandemic, but it feels as though the pandemic has been clarifying what we need to do and some of the broader and deeper challenges. So let me ask us broadly, and I'm open to all panelists participating in this question, where are we on this journey of 1,000 miles? If the endpoint, which we probably will never get to, but we can aspire to, is everyone in this country truly being connected not only to healthcare delivery and healthcare services and healthcare coverage, but also connected in the sense of being watched over in their communities in the best way by social service agencies, by healthcare providers, government agencies, everyone. And so where are we in terms of that connectedness of obtaining, storing, analyzing, and sharing data and using it to further those ends? Who would like to begin?
Mark, I'll jump in. When I think about where we are in the journey, I would say we're at the beginning stages. As a large integrated delivery and financing system, I think we understand we need to capture individual insights around their social risk. The opportunity to marry that with publicly available insights is another opportunity to integrate with information that's captured via resource and referral platforms like Find Help, which used to be at Bertha, Unite Us, Healthify. Those are all rich opportunities that I think we are still establishing. And as we are working through the construct of the health capture of social determinants and the interoperability through the Gravity Project, I think, again, we're at early stages, but the flywheel's picking up steam very quickly.
Okay. Others assessments?
Yeah, I'll jump in and concur. We're early. I think if anybody does a Google search, you'll find in high volume the little image that says, here's the pie chart. Social determinants are a really big influence on our health outcomes. So I think we've all evolved to accepting that notionally, but the visibility and the availability of that data, and in some ways the voluminous of that data, right? So in some ways we lack it completely, and in other places we're overflowing with data, and trying to sort that all out and make it genuinely actionable for people is where we're at, and that's really the beginning of the journey.
Yeah, I have to concur, Janine. It's that classic ancient phrase, water, water everywhere, not a drop to drink. We're flooded with data, but the ability to use it is so difficult. Klaus, I hope you don't mind. I am going to engage you in a very specific way, which is, I know that you're European and that you grew up in a different healthcare system. One of the challenges, of course, in the US healthcare system is the incredible fragmentation of it. What's your perspective on that? And I hope I'm not putting you too much on the spot by asking you as someone who has an international background.
Well, first of all, I'm also an American now, so I love being here with you all. I think social determinants of health is the focus that we have seen in the last 5 years, and especially catapulted with what we are learning from COVID and the response to that, and understanding how everything is interdependent and interrelated is really, really fascinating, and it bodes well for the future. Social determinants of health are so complex, and I'm feeling that health system and insurance carriers, they're realizing this interdependence and interrelatedness with government, with nonprofits, with houses of faith and other entities. But if we look at the Kaiser Family Foundation's framework for social determinants of health, remember it has 6 broad categories: economic stability, neighborhood and physical environment, education, food, community social context, and then the last one is healthcare. And in this discussion around social determinants of health, not the one that we're having here today, but nationally and locally, I'm really just seeing large health systems and insurance carriers and to some extent governmental public health stepping up and having this conversation. And so it's really key that all the other entities get brought into the conversation as well. Otherwise, we are not going to address any of the social determinants of health. So right now we're having this public healthcare forum on all these things, but people from transportation, from education, from the built environment, what have you, they're not at the table at all.
Yeah, exactly.
And I also feel that there's to me as a European, I'm in awe of innovative health systems like Casa Permanente. But when I hear that a health system like that is dabbling in public housing, because public housing is a fundamental determinant of health, I'm scratching my head, and I'm like, that really should not be the responsibility of a hospital. They should provide healthcare. So government and the private and other players in the private sector should step up so healthcare systems can really focus on the delivery of healthcare. So our challenge right now is to get all the other stakeholders into this tent, and then each of us will do our part.
Right. So let me. I think I'd like to stay on you, Klaus, as well as bringing Kirsty to talk about what the opportunities are to connect the provider world as well as the payer world. So hospitals, medical groups, health systems, as well as health plans and community-based organizations. Can you both speak to that? And then I'm going to go further about data, but let's approach that first.
Sure.
Maybe Kirsty, yeah.
Absolutely. Thanks, Mark. I have to echo the sentiments that have been shared by the rest of the panel, and what Klaus just immediately shared really resonates with us, because right now we're playing this convening role where we are trying to bring together sectors so they can each do their best work in their own roles. We all have a part to play, and so how do we think through understanding social determinants of health holistically, right? How are these systems interacting and affecting social risk factors such as food security and preventing families from meeting their daily health-related social needs, such as nutrition? All of these fit together, and we all have a different role to play, whether that's addressing the immediate food need, whether that's addressing the risk factor, or thinking through how these larger food, housing, economic, and education systems collaborate and interact, affecting, the downstream effects of all of this. And so in terms of the question about what's the opportunity or responsibility engaging with community providers, it's both. There's a great opportunity. They provide this wealth of perspective to really understand, right, the challenges that families are facing, not just in accessing healthcare, but accessing all of these other social needs and resources that they need to thrive and achieve overall well-being. And as a public health institute, we really believe in the power of data. You can understand the problems, you can figure out the resource gaps, and figure out how to address the disparities. There's power in data, and also we really rely on our community partners to resonate the idea that there can also be misunderstanding, fear, and real consequences, right, when we think about sharing data. So how do we bring that into the fold of the conversation, not as a barrier, right, but as a piece of the conversation to think through how we integrate all of our efforts across systems and data to do the work, that we're all here to do, which is really to advance health equity. And so I think I've hit on a few points.
Yeah, no, that's very good. Very good, Kirsty.
And invite Klaus to add.
You covered a lot. That was great. Klaus, the very name of your initiative, Cities Changing Diabetes, speaks to what Kirsty was just speaking to. Can you just talk about that connectedness and also data's role in it?
Yes, but I wanted to. I think I want to address the other question first. So
Okay.
so I'm feeling that you know, community-based organizations are so vital to our lives in society, and they are able to affect social determinants of health in ways that many other players are not. And so we have come to this situation where we are expecting, and when I say we, I say hospitals and insurance carriers and government, they're expecting community-based organizations to really step up and do a lot of the upstream work to reduce social determinants of health, so complex diseases like diabetes and obesity are averted. But that's a really tall order to ask community-based organizations who are under-resourced. And so we're in a situation right now where there's an asymmetry of information, and there's also an asymmetry of the capacity to analyze the data and to translate the data into solutions. And so that's where I feel that the resource strong players in the system, whether in the ecosystem, whether it's hospitals, government, insurance companies, or others, they have an opportunity to really support community-based organizations, so they have access to the same information, and they can really deploy that information as they implement their initiatives.
Yeah.
In Cities Changing Diabetes, and it's a global initiative funded by Novo Nordisk to come up with local solutions around obesity and diabetes prevention. In Cities Changing Diabetes in the US, we're really fortunate to have Novo Nordisk. Recently, they invested in a collaboration with LexisNexis, and so we are able to tap into all the data that LexisNexis has, and our academic lead in the US, the University of Texas Health Science Center School of Public Health, is massaging the data, analyzing the data, and then helping the community-based organizations in Philadelphia and in Houston use that data. So that's extremely promising. And I think that in every single community, hospitals and other players who are sitting on all this data, they have an obligation to democratize the data and make it available, because they're dependent on the community-based organizations to work on disease prevention and other really complex tasks.
Yeah, absolutely. And I'm about to bring Emily into the discussion too, but let me first, I just want to turn to Deb for a second. Deb, could you share with the audience, briefly explain what's happening right now with the Gravity Initiative and with USCDI, which is the United States Core Data for Interoperability Set? Some in our audience will have a tiny bit of awareness, many won't. So if you can give us the elevator speech, that would be great.
Sure. The Gravity Project is actually a multi-stakeholder public collaborative with the goal of developing, testing, and validating standardized SDOH data for use in patient care, care coordination between health and health services, health plans, resource referral platforms, public health, value-based payment, et cetera. And they're really developing the data standards to represent patient-level social determinants of health. They have two main work streams within their body of work. The first one is around terminology, and that's defining each domain and the codes that are necessary for capture, whether that's link coding, SNOMED, or ICD-10Z codes. And then on the flip side, under the technology side, that work stream is really focused on establishing the interoperability for data exchange using FHIR, IG, and HL7. So Gravity is really it's a public collaborative, but it is charged with developing that that ecosystem for social determinants across the country. And then this past summer, the Office of the National Coordinator published in their final US CDI rule, so the United States Core Data Interoperability version 2 requirements, that it would include Gravity's SDOH data elements, which that means that becomes part of that national infrastructure for interoperability and exchanges. So if it's not required today, you can envision in the near term where it will be required. So
Great.
it is a public collaborative, Mark. If Google it, you can join, you can participate in the domain development. You can participate by being a financial supporter of Gravity, as Highmark Health is. But again, I would encourage folks to take a look at it.
Wonderful. I want to make sure, thank you so much, Deb. I could not have explained that well. So thank you. I want to make sure to bring Emily and Janine in right now. Could you both react to everything that's been said and also just share your organization's involvement in this issue, or this set of issues? So Emily and then Janine, how about if we do it that way?
Yeah, great. Thank you. So I think, I'm not going to react to everything that's been said in the interest of time, but kind of following the thread through from, where we are as an industry and as a healthcare, sort of in the broader view of healthcare in social determinants, and taking it all the way through to kind of data democratization, which Klaus brought up. What I see is that we are still in the phase of defining the problem, defining what we mean by social determinants, and we have not yet evolved to a state where we are saying consistently, here is how we are going to tackle that problem. And I think part of that does stem from kind of data silos and different data being available for different kind of users. So one thing that our organization, kind of is focused on is encountering and kind of capturing ways in which to make information about individuals available in sort of less traditional ways. So Klaus mentioned the engagement that we have with Novo Nordisk. Under that engagement, we were able to anonymize data and kind of create population level insights that drive to understand the community in a different way. And I think that's a really important kind of avenue to go down to help understand, if you do not have a patient population that you manage actively the way that a payer does or the way that a health system does, how do you gain access to this information? And I think that same approach could apply to a community organization or a government entity, thinking about community level assessment as part of that. And then another initiative, that we want to tackle is really related to data tokenization and what data can be made available for de-identified use cases. So following and remaining compliant with HIPAA legislation, ensuring that data cannot be re-identified, but also ensuring that the information we have can impact decisions that are made about treatment effectiveness and really drive, other parts of the healthcare system as well. So I think it's about kind of, as an industry, working together to come up with a refined and consistent definition of the problem, and then work on how we tackle it in various ways, somewhat tied to the data as well as the programming and driving that forward.
Wonderful, thank you. I appreciate that insight. Janine, your thoughts?
Yeah, sure. Let me anchor on the asymmetry that Klaus talked about and the standardization that Deb talked about. So if we unpack this, part of the challenge of social determinants is the asymmetry, not only of where the data is, but the asymmetry of the accountabilities to use it. And I'll go one step farther than community. So we have our organizations, our healthcare organizations that are sitting on mountains of data, community organizations that are sitting on information digitized or in their heads, but then go one step further to your families and your neighborhoods, right? So sometimes the people closest to the patient or the member really have the greatest insight on what's going on, right? So with stuff way beyond the house you live in or your socioeconomic status, people know if you've declined. So I saw a post on Nextdoor recently. A lot of people are on that app, and literally the post was, hey, the woman who lives next door to me, she's a widow and she needs help getting her cat to the vet. Well, we can couple that with CMS Medicare Advantage supplemental benefits, which might actually offer an insurance benefit to cover social transportation in addition to medical transportation. So part of this is about unpacking that asymmetry and making information available in real time fluidly. So from the right source at the right time, we're going to have to navigate the digitization of that data, the rationalization of that data, and the usability of that data for whoever's accountable to make that decision. And sometimes it's the clinician, sometimes it's the community person, and sometimes it's your family. So like another quick story on that, a friend of mine has a diabetic parent, really old school. He's been diabetic for 60 years, doing all of his testing old school, had not even migrated to glucose monitors and whatnot. So they finally got him set up with a glucose monitor, but his family is his open loop control system. His family monitors the data. And I think that's what makes it so challenging. It has to be very personalized, yet we need the standards that Deb described in the background, making it possible to fluidly exchange data from all kinds of sources.
Yeah.
And that's the kind of stuff that we work on, and that CMS supplemental benefits, that's one area where we're working to say, look, here's something really concrete we can go do that's incentivized, and it's a step forward to that really fluid future state.
Right. I think that's, you put your finger on the complexity, I think, Janine, because it's all different things, right? Like it's a zillion different things that we have to somehow manage. And you triggered a thought in my mind. In medication administration, we have the 5 rights. We're going to need someone to come up with the 5 rights of SDOH management. So, Deb, tell us a little bit about Thrive 18, if you would, just very briefly.
Sure, and I think to your comment, Mark, I think we on the health side have to also be in it. I did not coin this term, but I've heard it and think it resonates. We have to be careful we don't medicalize this and expect that our community organizations and partners will now be little health sectors, and I think that would be a big mistake. So I wanted to affirm the comments that Klaus, Janine, and Kirsty had shared earlier around working with our communities by sharing information on a very local community effort. Highmark Health and the Buell Foundation here in Pittsburgh have invested in a community effort that is called Thrive 18. And Thrive 18 is in its intent designed to improve the health and well-being of the residents of the north side of Pittsburgh. It's a community that has a significant social vulnerability within that community. Project Destiny is actually the community benefit organization that is advancing this program. So this is a community effort led by that community organization. Highmark is a financial supporter, but this is not a Highmark program. And I often have to make sure my colleagues on the health side remember that this is a community effort, and we're learning how to work together, frankly, and that's one of the big value adds from this particular work. But the basic premise of Thrive 18 is they have hired outreach workers. Some of them have gone on to become certified community health workers, but they have an entire team of outreach workers that canvass the neighborhoods of the north side, door knock. Pre-pandemic, they door knocked. Post-pandemic, it had to take a different tactic. But they're basically trying to reach the residents, share with them what Thrive can do and how Thrive can help them address their social needs, and then ask for their engagement. They have, if they get a chance to talk to somebody and engage them in a discussion and a survey, they have a 93% actual engagement with those individuals. We would do cartwheels to be able to have, and like half of that, we would do cartwheels. So that demonstrates they're trusted in the community, and that, I think, number demonstrates that. This is very focused on what the resident defines as their most urgent need, and it is not health. And they are not trying to help somebody with their diabetes. I mean, if they need help and that's what they've articulated, they'll help them. But this is about what the resident defines, and their needs have been, not a surprise, food, housing, education, safety, utilities, transportation, employment. That's what Thrive is working with, making connections to social agencies that can assist those residents. So that's the work they're doing. I do want to say, and I have to, my my analytic colleagues would kill me if I didn't say that we are cautiously optimistic. But we are able to take a look at, for Highmark members that are engaged with Thrive, and so we have that claims insight, we're able to take a look at that and have the necessary authorizations, et cetera. And so early 6-month pre-engagement, 6-month post-engagement results are really demonstrating such strong impact. We're seeing very strong impact on ED utilization. So a very strong decline, climbing pre-engagement, very strong decline post-engagement. Same thing in cost of care. So again, this is the work of the community partner working in partnership with health. They will take a referral from our flagship hospital,
Right.
but they're working with the community.
Wonderful. Thank you so much, Deb. I really appreciate it. I want to keep us a little bit on time, and we have a very large panel. So I'm going to ask people to be somewhat brief, but I'll ask in a very nice way. So I'm going to ask Kirsty and Klaus, if you could each just spend like literally 2 minutes sharing an example of where your organization or some initiative that you're involved in has made an advance or two in this area. Either way, Kirsty, why don't we go with you and then Klaus?
Sure. So right now, or I should say over the last couple of years, Colorado Health Institute has been working with state, regional, and local partners on this concept of a social health information exchange ecosystem. And this is really about building a shared health and social infrastructure to bring together health, human service, community, even education partners to build this larger community of care around individuals and families, addressing the whole person, the whole family. We're definitely still in the nascent stages, but we do have the shared commitment and vision within the Metro Denver region for this, and are working through what sort of agreements, right, data, practices we'd need to follow. But of note, I wanted to call out within this larger infrastructure would be a community board, because we really do believe it's important to have both community-based partners and community members with lived experience at the table, saying these are our needs, these are our priorities, and not only our challenges, but here are also our assets. And let's include that in this overall work. And so I'll pause there.
Wonderful. Thank you. And Klaus, I'm sure Cities Changing Diabetes is making real headway in a variety of areas. If you can just maybe zero in on one or two that we might want to know about. Oh, and you're muted. We don't want you silenced.
No.
Please go ahead.
So in Cities Changing Diabetes, one of the things that we set out to do in the beginning, we have what we call a mapping phase. And then out of that mapping phase, the local stakeholders translate the data, the research into solutions, and then they implement those solutions. And in the mapping phase, we found that vulnerability for diabetes was really an important factor. And in Houston, we looked at individual vulnerabilities. So we segmented the whole population into 4 different groups. Financially pressured caregivers. So people who really don't have the time to take care of their own health because they are commuting to pick up a child or take their mother to the doctor. Isolated skeptics who don't trust the healthcare system or government, and then concerned seniors who are isolated in their community and don't really understand the healthcare system anymore. They don't have 35 or 45 minutes with the doctor like they used to, and then time pressured young adults. And one of the communities that we ended up working with was communities of faith. And so in Houston, we have had 2 cohorts of 23 different houses of faith. So Christian, Hindu, and Muslim faith-based organizations have been trained in delivering a diabetes self-management education and supports program, and it's really been successful. we took that program to Philadelphia, but we asked the houses of faith in Philadelphia to develop their own interventions, and that is really exciting to see as these are being implemented right now. We worked with a Danish global urban planning firm called GIL, and in Houston and in Philadelphia, they helped a federally qualified health center and the food bank to understand the local foodscape. And out of that work, new interventions around local food systems are emerging. So there's a lot of interesting innovation happening in cities changing diabetes, and we hope to scale that up in each of the 2 cities and beyond.
Okay, great. And I just want to be responsive to one audience member, but the question that they're asking is so broad that we could have 10 sessions on it. But the question is, Klaus, are there any European countries doing this well that we can learn from? And I know the systems are very different, but if you could just briefly maybe mention.
So there are 40 cities around the globe that are participating in cities changing diabetes, and so everyone is really implementing the program based on their local resources and capacity needs and the culture. And it's interesting to me to see what's happening in Leicester, Manchester, and Liverpool, where they're working closely with the football clubs, soccer clubs, as a way to get to men who may not be have that healthy behaviors. And in Copenhagen, the focus is in an immigrant neighborhood that has been really hard for health authorities to connect with. So you can go to citieschangingdiabetes.org, Laura, and you can read all about it there. Or you can reach out and get my information. I'll be happy to connect you to the projects.
Wonderful. Thank you so much, Klaus. And if you wouldn't mind, maybe, Klaus, you could put your email in the chat while we continue. That would be so helpful. Let me we're already running out of time. We had such a wonderful panel and so many questions and issues. Let me turn to Emily and Janine briefly. Let me ask you both, what do you see as the biggest data management? I mean, management is such a funny word in this context, but the biggest data handling issues right now, and how are we going to quickly or not quickly get over them? Emily, and then Janine, do you want to do it in that order?
Yeah, I mean, I think there are obviously so many challenges, as it relates to healthcare companies who are oftentimes really, a lot of security and safety protocols for managing data. And I think sometimes the historic incentives have been aligned in such a way that we create separation even within an organization around the data. We create lack of access because we've been told that that's a way in which we can increase the security of the data that we have that is sensitive. And sometimes those boundaries make it harder to try to come together across an enterprise, or especially when you're talking about working with outside partners to solve problems like this. So what I see a lot when we work with customers who want to onboard something like the LexisNexis social determinants data is there has to be someone involved in the project who has purview into the various both work streams and data management systems in order to correctly connect those dots and put the process in place that will allow the data to flow downstream to where it needs to be. So I think overarching themes to me are understanding kind of how the different systems integrate and being able to address concerns around, security and privacy in such a way that we don't lose the utility of kind of the systems that we have in place.
Yeah, absolutely. I agree. Janine?
Sure, yeah, I'll highlight 2 things. So I, as an individual, I thrive on complexity, and that's one of the challenges. So you highlighted it before, lots of complexity. So one of the things we need to do is cut through that complexity and find really concrete, actionable things we can do with this data, things we can do short-term to get some immediate return. And whether that's anchoring, like I said before, on CMS special benefits or a community need or transportation or whatnot, but concrete. And then the second part of that that's necessary to make it work is operational definitions. So this is a perennial problem with measurement. It's been a problem for decades, even within organizations that use well-established measures. Two people talking about the same measure by its label, but they mean entirely different things. So in social determinants, if we think about past trauma, so somebody's past trauma might completely inhibit how they engage in any of the many things we've talked about. So what do we mean by past trauma? How do we measure it, et cetera? So operational definitions are really crucial, and then very concrete, actionable near-term endeavors.
Wonderful. Thank you so much. Let's move forward quickly if we can. What is this landscape going to look like, let's say 2 to 3 years from now? And let me start with Deb and Kirsty, if I could. And Deb, I'd especially like your health plan leader view. How will this all be playing out in a couple of years? Oh, and you're muted.
Sorry, I thought I just clicked that. I would hope that that social risk becomes part of how we just look at and understand people, as well as clinical and behavioral risk, and that we evolve from. I see today it's still a lot of a bolt-on, and you know we have a lot of work to do just to help people understand. And I think, you know, Janine, you brought out a very good point. You know, this is not the same way we can't work with individuals the same way around social risk that we would have around a clinical issue. So that's a big change for health broadly, as I see it. But you know, if I look 5 years down the road, 10 years down the road, I would hope and envision a time when the next new network that a health plan works with are CBOs. Today, they're not part of our contracted networks. That we will now have robust, you know, ICD-10 codes that are being exchanged and captured, and we've evolved all of our value-based programs to integrate social risk into those programs. And that you know, I think at the very beginning of our conversation, we talked about, you know, and Klaus, you did a great job of saying, like, why is health in the middle of some of this? You know, I think we have to be a convener, but this is not health alone to solve. And so I think there are many ways we need to advocate and convene to bring others to the table.
Yeah, absolutely. Kirsty, your thoughts?
Yeah, Deborah's final point about this is not just a healthcare system problem to solve. Yes, and I think what we're hoping for moving forward in the landscape is not just incentives, but actually sustainable funding mechanisms that will support all these partners coming together, especially, to Klaus's point earlier, community partners that are critical and don't get paid, right, on their daily jobs to do this sort of work. And so if I'll keep it short, I think really we're hoping in the years ahead, we start thinking through more sustainable funding ways where we all can come to the table to work on this.
Wonderful, thanks. Let me just, we are actually running out of time, so we have a large panel. I would like each panelist to give us 1 minute of closing advice for all those who might want to participate in the myriad possibilities that are out there. And as you all know, most of our audience is in provider organizations. Some are not. We have a few plan people in the audience and others, but most are providers. They're in hospitals, medical groups, and health systems. So I'm going to ask each. We literally have 1 minute for each for each panelist, and I apologize for that. We just have such a cornucopia of wonderful people here. Let me just go. I'm looking at my little Brady Bunch screen here. I'm just going to kind of go in order. I see Emily. Why don't you go ahead, Emily?
Yeah, thank you, Mark. So I think kind of really highlighting something Janine mentioned, and a theme we've talked about already, figuring out how you can come up with a sort of a problem that is of a size that can be addressed on the short term. I think we all know that our organizations are more likely to support things for which there is evidence. So if we kind of bite off a giant problem and it's going to take 5 years to see the return on that, it's going to be problematic to get the engagement. So if you can come at the problem in a more kind of concrete way, maybe take a specific population with a specific risk profile, or engage with a program or community partner that you know can offer a certain type of service and try to identify those at risk and tie them together. I think that would be a way to see that incremental progress could be made and drive forward with the next bigger step next time.
Wonderful. Perfectly said. Thank you, Emily. Janine, I'll go to you next.
Sure, second that, and spend the time up front on your operational definitions. So that old adage, measure twice, cut once, applies here. It pays off to think through what the measurement really means, how you're going to capture it up front. And for all the techies that are out there, spend time thinking how you're going to modularize whatever it is you build for that short-term win. Because down the pike, what we need is a whole bunch of Lego building blocks out there that we can compose and recompose as needed.
I'm so glad you mentioned Lego. Lego is originally from Denmark, which leads me to Klaus, if you don't mind going next, Klaus. Advice for our audience.
I think we need to invite government into this whole conversation. So they have a special role that they can play in connecting the different sectors that contribute to improving social determinants of health. And a good example of the power of government is what they're doing in the State House in Harrisburg, Pennsylvania, where Pennsylvania Medicaid is telling Medicaid insurance carriers that they can actually contract with community-based organizations on social determinants of health related work. And this is just in the early beginnings now, but I think that government just has a special role to play in order to get us all to interact in the way that we need to.
Wonderful. Thank you so much, Klaus. That was great. Deb.
Agree with my colleagues, but I'm going to take a different direction. I'm going to say if you are not involved or familiar with Gravity, please take the time to be involved. Let your voices be heard. This is part of what's being built nationally, and it's what we will all leverage as we move forward. So again, let your voices be heard.
And you get a special prize for succinctness. Thank you. And finally, Kirsty.
Again, I agree with everything that's been said, but to add maybe a different perspective or add some flavor, I think we are learning that we cannot evaluate this work with traditional forms of metrics. We can't just look at ED utilization or cost savings, et cetera. It's that, and if we're addressing social terms of health, how do we think through measuring impact to school performance, employment participation, upward mobility? It's much bigger than just specific health outcomes. And I think that comes back to the point that this is not just a healthcare and cannot be a healthcare centric problem. So I'll add that.
Okay, I think that's wonderful, Kirsty. I will say, to balance out, I think I completely agree with you. I love how you and others say something and. So I'll say that, and I also agree that we're in this interesting situation where healthcare leaders need to participate in this work, but also kind of have some clear boundaries so that things don't get all completely mushed, so that it becomes boiling the ocean. So, but I believe that the future is bright in one way, in that we as a society have identified that social determinants of health are incredibly important and that we need to work on them. And I agree with everyone that we're early on in the journey, but there are so many wonderfully intelligent, dedicated, goal-oriented people involved in this. I feel good about the next 3 years. So I just wanted to thank everyone on my panel. You've been absolutely wonderful. This is a huge issue, and we're going to be talking about it in the future, and hopefully including all of you again. Thank you all very much. Matt Rayner is back magically to close out the session, so I'm going to thank you all.
Yes, thank you, Mark, and thank you, panelists. A great, fantastic way to kick off our Population Health Virtual Day. We are now on a very short break of all of 5.5 minutes before our next session, which will be exploring NYC Health and Hospitals SDOH strategies. So we will be closing this Zoom session. You can simply click on the next Zoom link to join us. We'll be starting right at 1 o'clock Eastern time. So we will see you all shortly. Thank you.
Thank you all.
Thank you.
Bye.